Hi, everyone, and thank you for joining us. This is Kate Berry, CEO of National eHealth Collaborative, or NEHIC. We are very pleased to welcome you to the first class in our NEHIC University Spotlight Learning Series on the Learning Health System. NEHIC is a public-private partnership working to advance nationwide health information exchange, including educating stakeholders about health information exchange and related topics. For today's class, we're very pleased to welcome two of the foremost leaders on the learning health system, Dr. Charles Friedman, Chief Scientific Officer at the Office of the National Coordinator for Health IT, and Dr. Claudia Grossman, Program Officer for the Institute of Medicine's Roundtable on Value and Science-Driven Healthcare. I'll introduce our speakers in just a few minutes. Next slide, please. Before turning it over to Chuck and Claudia, I wanted to briefly highlight our new NEHIC University class schedule. As many of you may know, our NIN University program has been rebranded as NEHIC University, featuring new programs that provide a broader view of the health IT landscape. Next slide. Since we launched NEHIC University earlier this month, we've held two successful new sessions. On May 18th, we were joined by health IT expert Michael Lake, president of Circle Square, for our first health IT orientation class. This was a very popular and well-attended session with extensive Q&A. Michael taught us nearly everything we needed to know to have a solid foundation in health IT in less than 2 hours. We will offer this class quarterly, so watch our website for upcoming dates. The recording of last week's class is available on our website. Last Friday, we were joined by Chuck Parker, Executive Director of Continua Health Alliance, for our first Industry Leader Briefing. Industry Leader Briefings provide attendees an opportunity to participate in interactive discussions with health IT thought leaders. This was an outstanding, informative, and highly interactive session. We welcome industry leaders Paul Urich, General Counsel for Surescripts, and Holt Anderson, Head of NCHICA, for upcoming leader briefings this quarter. A recording of the industry leader briefing with Chuck is available on our website as well. Next slide. On June 8th, Michael Lake will be back with us to deliver an in-depth briefing on innovations, new developments, and market trends in health IT. This program will cover major business and policy developments, updates on health information exchange and health IT initiatives, and how they are transforming healthcare financing and delivery. Health IT trends will help attendees stay on the leading edge of the rapidly evolving health IT ecosystem. This class will have a small fee of $100 and will include a special subscription to a monthly health IT trends report. Next slide. The Health IT Policy and Standards Committee's quarterly updates will help attendees keep up with the many activities of the federal advisory committees and their work groups. These updates will not only be a chance to stay up to date on the developments of health IT policy making, but they will also provide an opportunity to engage with and offer feedback to the Office of the National Coordinator. On June 13th, we are pleased to welcome Jody Daniel, Director of the ONC Office of Policy and Planning, who will kick off this quarterly program. Next slide. This quarter, NEHIC University is offering two Spotlight Learning series. The Learning Health System series begins today with an introduction featuring our two distinguished speakers. The series will continue with ONC's Chief Privacy Officer, Joy Pritz, and Laura Adams from Rhode Island Quality Institute to talk about ensuring the public trust. Now, please note that this is a date change, so that session is going to be on June 14th. And in the final class of this series, we'll wrap up with a discussion of the technical infrastructure required to build a successful learning health system. The second series, Spotlight on Accountable Care Organizations, will examine the new environment of accountable care and how health IT is a critical enabler in improving healthcare quality and care coordination and better managing costs. We've got an exciting agenda planned for this series, including a look at ACO critical success factors, as well as practical implementation. So the wrap-up of the Accountable Care series will be hosted by John Glasser, who will help us review some emerging models for accountable care development. Next slide. Throughout the year, Nihik University will also offer special guest lectures ranging from industry announcements and updates on policy and market developments. Please visit the website and watch for announcements about these events. Next slide. NIN University will continue to be a premier feature of NEHIC's education programs. The ongoing NIN University 300 series will continue as scheduled on June 20th with NIN 304, HIE Success Stories from a Patient Perspective, which will focus on the benefits of interoperability from the patient perspective. On July 18th, ONC Standards and Interoperability expert Doug Frisma will wrap up the series with a discussion of the National Strategic Roadmap for Health Information Exchange. Next slide. As always, you can download and print today's slides at the URL on your screen. The recorded webinar will be up within a couple of days, and we will have the full transcript available within 10 days. You'll also find helpful links and other materials to help you learn even more about today's topic at the NEHIC website. Next slide. During the presentation, please feel free to enter your questions at any time in the Q&A window at the bottom right-hand side of your screen. You can also email us, tweet a question, or comment on our Facebook page. So now I would like to introduce our speakers. First, we have Chuck Friedman, as I mentioned, the Chief Scientific Officer for ONC. And as ONC's Chief Scientist, Chuck leads a group responsible for tracking and promoting innovation in health IT, for research programs to improve technology, for applications of health IT that support basic and clinical research, for evaluation of all ONC's programs, for programs to develop the health IT workforce, and for activities supporting global e-health. Chuck served as Deputy National Coordinator for 2 years prior to assuming this new position. He also was the lead author of the National Health IT Strategic Plan that was released not too long ago. And Claudia Grossman, as I mentioned, is Program Officer for the Institute of Medicine's Roundtable on Value and Science-Driven Healthcare, and she supports the Roundtable's work in the areas of clinical effectiveness research and health information technology relating specifically to the development of a learning health system. So I'm very pleased to now turn the podium over to Chuck.
Thank you, Kate. I hope everyone can hear me. If I am not audible, I trust somebody will tell me. Okay, I assume I'm audible. Let me move very quickly to go over today's agenda. Claudia and I have decided to give you something of an integrated presentation today. I'm going to lead off and do the first part of this integrated presentation and basically introduce the concept of a learning health system and in somewhat general terms a strategy that will move the nation in that direction. Then I will turn the virtual podium over to Claudia, and Claudia will discuss the activities and findings of a series of workshops that were conducted last year, sponsored by ONC, but organized with incredible dexterity by the IOM. The report coming out of that series of workshops was actually formally released, even though a preliminary version was released in December last Monday, this past Monday, and Claudia will be reviewing to give more detail to my general description of the learning health system, the key findings from this IOM report. And then Claudia will turn the virtual podium back to me, and I will very briefly discuss some near-term specific projects that are getting underway to move us a bit closer to this goal of a national learning health system. So I'll now embark on part one, which is my introductory talk. And this introductory talk will have three main points comprising it. Point one will be to emphasize that the National Health IT Agenda specifically targets a learning health system. This is not a sideshow or an afterthought, but rather a key element of the national agenda. My second point will be an important one to illustrate that meaningful use, while absolutely vital to move us toward a digital health system, is necessary but not sufficient to build a health system that learns. And I will introduce this formula that meaningful use plus some delta will get us to the learning health system, but meaningful use by itself will not. And then I will very briefly talk about where we are in advancing toward meaningful use, because that is a building block of the learning health system, and thus worth emphasizing and reviewing today. So what is a learning health system? I will give you here the definition that the Institute of Medicine, which has been promoting this concept of a learning health system for many, many years now, uses, and Claudia, I know, will introduce this definition as well and possibly elaborate on it. But let me just show it to you here and read very briefly that a learning health system is one in which progress in science, informatics, and care culture align to generate new knowledge as an ongoing natural byproduct of the care experience and seamlessly refine and deliver best practices for continuous improvement in health and health care. So a learning health system is one that, by its very nature, has the capability of reusing information that might initially be collected for purposes of healthcare. All of this predicated on a basis of trust and patient consent, to make that information a resource through analysis for learning and continuous improvement. So what are some ways a learning health system might work? Before I get into two scenarios illustrated on this slide, let me just remind everyone, and I think everybody knows this much used and perhaps overused statistic, that it currently takes 17 years for a new validated item of biomedical knowledge with implications for healthcare to find its way into routine use in healthcare. A very good way to think about what a learning health system could do is seen at the top of this slide. A learning health system, if it's up and running and working well, will take that 17 years and make it into 17 months, or depending on the specific circumstance, 17 weeks or even 17 hours. For some circumstances, very rapid learning may be required to take advantage of what the system is capable of. So here are two examples. In the first, we consider a situation where post-market surveillance of a new drug reveals that the personalized dosage algorithms that have been developed for that drug need modification. This anticipates a day when genomic information might be used to personalize the dosage of a drug. This is already starting to happen in many places. If this ongoing post-market surveillance of the drug through actual experience with the drug reveals that the algorithm needs tuning, to a fully developed learning health system, a decision support rule could be created or modified and very, very quickly implemented in EHR systems. I don't know what the time frame for that would be, but with a true learning health system, it would certainly be less than 17 years. Another example of a learning health system in action takes us back to the recent experience with the H1N1 flu. With a fully elaborated learning health system, new cases of a rapidly spreading disease could be reported directly and automatically from EHRs to local, state, and national public health. And as the disease spreads into new areas, or is anticipated by geographical tracking to be spreading into new areas, clinicians in places that the disease has not yet reached but will reach soon might be alerted to be on the lookout for the symptoms complexes that are characteristic of the disease that is spreading. And again, here is an example where rapid learning, certainly more rapid than 17 years or even 17 months, is going to be required. But this is something that a truly fully elaborated learning health system will be capable of. So to return to the point about this being part of the health IT agenda for the nation, I want to emphasize that this is been actually part of a consistent federal vision going back at least as far and probably further back than that as the 2004 Strategic Framework for Health IT that was released by the first national coordinator, David Brailer. And if you go back and read that strategic framework, you will see that one of the four key framework components was the improvement of population health. And if you read the description of that, where population health is described as health IT supporting public health research and quality, although they didn't use the name learning health system, you will see that in that strategic framework that was really what they were talking about. Similarly, in the 2008 Health IT Strategic Plan, the first fully fledged strategic plan that was produced, population health defined in the same way as it was in the 2004 Strategic Framework, namely the mobilization of health IT to support public health research and quality, was actually one of only two goals in that plan, and of the 8 objectives, strategic objectives in that plan, population health and thus the learning health system was a focus of 4 of them. In the next strategic plan, the 2011 revision of the 2008 strategic plan, which was mandated by the HITECH Act, an initial version of that plan was recently out for public comment, and I hope that many of you had an opportunity to read through and comment on it. Those of you who did will have noted that the learning health system explicitly is one of 5 strategic objectives of the plan, and as I'll show you in a moment in the next slide, elements or aspects of what will be required to build a learning health system are represented substantially in the other 4 strategic objectives of that plan. This slide illustrates the high-level structure of the 2011 Health IT Strategic Plan, which was out for public comment and will be released in final form soon. You will see that Goal 5 articulates the achievement of rapid learning and technological advancement. That is a learning health system. And if you look at the other 4 goals, I think this will be clearer as the talks unfold today. There really are key elements of what will be required to achieve rapid learning and a learning health system seen in these goals. Specifically in Goal 2, which addresses improving care population health and reducing care costs, there is this little excerpt which I added to the slide verbatim from the plan, that two-way interaction between research and clinical care facilitated by Health IT has the potential to accelerate the generation of important new information on medical interventions, personalized treatment, and public health initiatives using population-based language, that sounds like a learning health system to me. It certainly sings in that key. So my point here, and I won't belabor it, is that a learning health system, maybe not by that exact name, has really been envisioned as a key component of the National Health IT Agenda, pretty much back to the birth of that agenda as a nationally coordinated effort. Which brings me now to the second of my main points, that meaningful use is necessary but not sufficient to build a learning health system. So what do I mean by that? Meaningful use is obviously the cornerstone of the national program and is a game changer, as it has been referred to by many, as both a concept and a concrete achievement that will dramatically improve individual and population health in this nation. That said, by statutory definition, meaningful use is a status achieved individually by eligible professionals and hospitals. By contrast, and excuse the circularity of this, if we are going to build a learning health system, it must be a system, something with systemness that includes professionals and hospitals that are meaningful users of health IT, that achieve that status individually, but binds them together in some way. And in that sense, you can see from the third bullet of the slide some things beyond meaningful use that a functioning learning health system is going to require. It's going to require systemness, which means real or implied membership, some form of organization, and some form of government. And let me say, by membership, I don't necessarily mean that entities, that everybody will carry a card as a member of the national or regional learning health system. But those are all details to be worked out as this unfolds. But there will need to be some sense among those participating in a learning health system that they are part of something larger than themselves that functions as a system. A learning health system clearly also requires public trust and a kind of support that can only be built through patient engagement. I know Claudia will refer to that in more detail in her talk. It will require some ability to aggregate data from various places and assemble it for analysis. This does not necessarily mean that data will have to physically move from one place to another, but it does mean that data from different parts of the system will need to be made available for analysis as if it were assembled in one place. We are talking here, one can say, about information exchange of a very, very sophisticated form. And of course, I should emphasize that in a learning health system of any type that is currently envisioned, data that will move only through in a way that is supported by a trust fabric that is built through patient engagement, and I'll talk a little bit in a moment about how we can take advantage of elements of trust fabric that are being built for meaningful use and build the learning health system's features on top of that. A learning health system is also going to require an analytic capability to transform data into knowledge. And finally, in order to work, there will need to be a way for the learning health system to disseminate that knowledge that is generated through these analyses back to the member agents of the system to influence their behavior and change care and population health for the better. You'll see at the bottom of this slide an article that I, along with Adam Wong and David Blumenthal, wrote expressing many of the ideas that you're going to hear today. So just to elaborate this point about meaningful use, if you sort of boil meaningful use down to its essence, you get a picture that is represented here, viewing meaningful use structurally as including the adoption of certified EHRs, the gold medal to connote certification, by hospitals and eligible professionals. The ability in a trusted way for those entities to exchange health information, and for various purposes, unidirectional reporting out from these information environments to entities to whom these reports can be directed, and that will put them to good use. This, in essence, is what meaningful use comprises, and I drew this picture this way to emphasize how meaningful use is necessary but not sufficient to create a learning health system. And to make this clear now, here is a picture. There are lots of ways, and I've always been challenged to try to draw what a learning health system would look like. This is my best attempt to date. And what you see here is something that looks a little bit differently from meaningful use. What you see here is a number of entities of different types bound up in a system with governance predicated on patient engagement and trust, capable of real or virtual data aggregation and analysis, and also dissemination. I've put this in a cloud, not to connote literally that this will be done through what is currently known as cloud computing, but rather to connote that mechanisms to do all these things that engages all of the participants in the system will need to be present for the system to work. Another key to this is the bidirectionality of the arrows, and one might think, therefore, of a learning health system as having afferent and efferent arms. The afferent arm in the system, denoted by the black arrows and the black labeling of the word afferent, relates to the essential capability of a learning health system to, in some way, shape, or form, assemble data from various parts of the system for purposes of analysis and generation of new knowledge. And the efferent arm, in that reddish-brown color, and the arrow going the other way, refers to the equally important capability of the system to distribute that knowledge that is generated back out to the members, so that these individuals and institutions can put that knowledge to use in pursuit of improved care of individuals and populations. So the bidirectionality of a learning health system, as opposed to the unidirectionality that is required by meaningful use, is a key difference and a key reason why the learning health system or meaningful use is necessary for the learning health system, but not sufficient. So I'm just showing here again these two scenarios to make the point that in the first scenario, the post-market surveillance of the new drug is an example of the afferent arm of the learning health system in operation, and the implementation of the modified decision support rule is the exemplification of the efferent arm, the ability of the system to disseminate the new knowledge that is generated back out to the members and constituent components The same point holds for the second scenario. The afferent arm is expressed through the reporting of new cases directly from EHRs, and the efferent arm is expressed through the alert of clinicians that the disease is about to spread into their area. So let me make a couple of points about the learning health system as currently envisioned that I think are very important points to make. First of all, the learning health system that we envision as strongly implied by the way I've represented it pictorially is some kind of federation among entities, and I am not, I repeat, not talking about creation of a single centralized database. I cannot emphasize that point enough. I also can't emphasize enough the fact that the learning system must be grounded in public trust and patient engagement, and that's why I listed it here again, even though I had said it already. The learning health system will need governance of some sort, not necessarily by the government, but it will need governance of some sort, and we believe it must be some form of governance that is participatory in the sense that the primary actors in this governance mechanism will be those who are participating in it. Last point, I know that Claudia will definitely emphasize this, is that in developing a learning health system, it will be very, very important to get just right the amount of standardization. And we believe that the standardization should be just enough to enable the kinds of scenarios I'm describing to occur, but not so much to stifle innovation and stifle development of the system by over-standardization that makes it difficult for things, once implemented, to be changed. So, back to this formula, that meaningful use plus some delta will be required to build the learning health system. One way of looking at the Institute of Medicine report that Claudia will describe in just a few minutes is that it was an initial investigation of what this delta will look like. But I will add at this point, and this was bedrock to the deliberations that took place during these workshops last year, is that the findings of the IOM report pretty much anticipate nationwide meaningful use. Now, we're not there yet, and I'll get to that point in a moment, but I think we need to anticipate that the nation will progress gradually toward meaningful use, and the learning health system can be built on top of that. So what are some of the things that the learning health system will inherit from meaningful use? Well, first and possibly foremost, it will inherit digitized and therefore computable health data. In other words, data that can be, under appropriate circumstances, reused to improve population health by supporting research, quality improvement, and public health activities. You can't build a learning health system that will work in any sort of the ways that I have described on health data on paper. It's possible in principle, but cannot possibly work fast enough or efficiently enough. The learning health system will inherit from meaningful use a substantial level of standardization. Adopted standards for information representation and supporting health information exchange will be a result of the movement toward meaningful use. Other standards are going to be needed to make the learning health system work, but the standards adopted through meaningful use will play an important role in the system's operation. The health information exchange capabilities, that number 2 in my little diagram that I showed before, are easy to diagram, more challenging to develop, but as they are developed, and there are mechanisms in place to exchange health information. Those mechanisms will be an important foundational element of the learning health system. The HITECH Act required development of a governance of the Nationwide Health Information Network, that health information exchange, which is required to support meaningful use. And however that governance, which is currently under development, evolves into being, it will be a useful resource for the learning health system, even though additional elements of governance on top of what is required strictly for health information exchange may be necessary for the learning health system. And last but certainly not least, the privacy and security framework and policies under development now to support meaningful use will play a critical role in formulating policies that may differ in some respects, but will be certainly working in support of the same principles to enable the learning health system to function. So very quickly now, just to review what some of you may already know, I said earlier that we are not at national meaningful use. In some ways, we are just getting started in the advancement toward national meaningful use. Let me just show you a few statistics to give you a sense of where we are now. The first of these relates to electronic health record use among office-based physicians. These data are reported each year via a survey conducted for us by the Centers for Disease Control and Prevention. And what you see here in this diagram is that we are somewhere in the 20%, high 20% range of office-based physicians in terms of adoption of a basic electronic health record. A basic electronic health record in terms of extent and nature of use of it falls far short of what stage 1 of meaningful use requires. So I think what you see from this diagram is that we are only embarking on the road toward meaningful use in two respects. First of all, only 1 in 4, slightly more than 1 in 4 office-based physicians even has a basic electronic health record, and then from the other perspective, a basic electronic health record for those who have it represents a level of use that is significantly short of meaningful use. In hospitals, here is the comparable statistic. About 19% of hospitals have a basic EHR, again through an annual survey, this one conducted by the American Hospital Association. This figure, I believe, is a little bit misleading because a hospital that has a basic EHR must have deployed a specific set of 8 functions. A hospital that has 7 of these 8 or 6 of these 8 will not count as having a basic system. So I don't think this slide is saying that only 19% of hospitals have some level of EHR deployment. In fact, something like 3/4 of hospitals have electronic lab result reporting as an evidence of a significant start on EHR deployment. But in terms of having a basic EHR, which is itself a significantly lower level of use than meaningful use will require, this is where we are right now. So we are on the road, but we have a ways to go to get to national meaningful use. However, there is momentum building. 41% of office-based physicians on a recent survey said that they intend to apply for meaningful use incentives. And please don't interpret that to mean that 59% said they would not, because 40% said they were uncertain, and we, of course, hope that the uncertains will eventually resolve their uncertainty into a decision to apply for meaningful use incentives, which means to do what is necessary to become meaningful users of an EHR system. 81% of hospitals indicated that they intend to apply for meaningful use. Another indicator of the momentum is the stimulation that all of this has generated in the health IT industry, as there are now more than 700 certified EHR products. And for these and other reasons, there are several projections that were actually done independently that anticipate that the nation will be at something like 80% adoption of electronic health records by 2019. So this brings my part one. I'll turn this over to Claudia in a moment. Just about to a close. I've tried to make three major points: that the Learning Health System is integral to the National Health IT agenda. It is not an add-on or an afterthought, and not only is it now an integral part of the agenda, but it really always has been. I've tried to illustrate in a graphic and I hope clear ways why meaningful use, as important and sophisticated as it is still not sufficient to build a learning health system. Thus, we need to focus on the delta that, when added to meaningful use, will take us all the way to a learning health system. And in my third point, I showed some statistics indicating that we are really, in some ways, just getting started in the move toward meaningful use, which will be a foundation for the learning health system. But momentum is building, and there are reasons to believe that by 2019 we will be well on our way toward having a national digital health system that is comprised of eligible professionals and hospitals that have achieved the status of meaningful use. So our strategy then can be thought of as having three parts, and I don't think we can wait for one to do the other. I think we can simultaneously build toward national meaningful use, as I just described, number one. Number two, build this delta, which Claudia will describe in more detail in just a moment. And finally, very, very important, coordinate these efforts, doing each of these, that is, building toward meaningful use and building the delta in a way that anticipates the other, so that each one reinforces the other and we have an integrated whole at the end of this process. So that completes my remarks for now, and Claudia, I will turn this over to you. Thank you very much.
Okay, great. Well, thank you, Chuck, for that, and also thank you, Kate, and all the folks at NEHIC for the opportunity to present this. So as Chuck mentioned, I'll be talking about the digital infrastructure for the learning health system, the Foundation for Continuous Improvement in Health and Healthcare, which is a report summarizing a series of workshops convened by the Institute of Medicine and sponsored by ONC, which were held last year, and as Chuck mentioned, we just released the full-length report on Monday. And I'll tell you this now and remind you that the report is available for free download at the IOM website. So next slide, please. So here's the definition of the learning health system that Chuck pointed out before. And so I won't reread it, but I think what I'll do is just reiterate the fact that really the core of this learning health system are these feed-forward and feedback loops that Chuck referred to and diagrammed as the efferent and afferent arms of this process. And it's really these loops that allow for knowledge generation, dissemination, and implementation, which really are the core theme that run through this report, as well as the other work that the Roundtable has been doing, and really provide the ability for a continuous improvement. The next slide, please. So as Chuck mentioned, the Roundtable on Value and Science-Driven Healthcare has been in function for about 5 years now. We actually used to be called the Roundtable on Evidence-Based Medicine, so you might have known us by that name. But really since the beginning, the Roundtable's activities have been focused on the learning health system. over the past 5 years, we've produced products, 10 of which are listed here, and these are summaries of a number of different meetings and workshop series that have been held, really to get at the specifics and start to develop some more of the details around what a learning health system might be. So we've done everything from more thoroughly articulate the vision, to talk about the care complexity which underlies the need for such a system, look into the opportunities afforded by approaches such as systems engineering that might be leveraged for a learning health system, and then most recently, before this digital infrastructure report, we took on the questions of costs and value around healthcare. I should mention that as a roundtable, we are a slightly different form of the Institute of Medicine than the consensus studies that most people are familiar with. So our main function is actually to convene folks, to convene workshops and facilitate discussions. And so these publications, as well as the digital infrastructure report, are a reflection of those discussions and a synopsis of them, but do not contain formal IOM recommendations. Next slide, please. So over the course of the 5 years and the number of different approaches that we've taken to defining a learning health system, we've really started to flesh out more specifically what this sort of a system will look like. And Chuck talked about this sort of at the 30,000-foot level, but we started to get a little bit more specific and break it down into some of the specific characteristics that are listed here. And I won't go through them individually because I'll get back to the ones that are most appropriate to this discussion in a second. But just to really say that this is a very rich area of work, and there are a lot of very complicated and overlapping and interconnected concepts included here. So I'll try to sort of simplify things and maybe draw some distinctions which are a little bit more straightforward than maybe they should be. But I'll let you sort of read that on your own pace. Next slide. So the digital infrastructure for the learning health system, what we are sort of referring to as the engine for the learning health system. I think digital infrastructures and sort of the health IT have been referred to using a number of different metaphors, but the engine is really one that we think fits best. And the reason for that is because we think that it really captures the fact that this is what is necessary in order to really drive that continuous learning and improvement that are really at the cornerstone of a learning health system. So Chuck detailed a lot of the progress that has gone on in meaningful use, and really this report is a reflection of sort of both ONC and IOM coming together and really feeling like we needed to seize the moment. So the way we characterize it is that health and healthcare are going digital, and there are a number of different efforts and foundational progress going on, including meaningful use, as well as some other things that really have put the nation at a point which needs to be seized in order for this learning health system to be able to be rooted in this digital infrastructure. So the time is right, and so these workshops were really meant to seize on that opportunity and foundation and think about, as Chuck mentioned, what else we need to do to make sure that we can sort of get the full way. So next slide, please. So here, just taking a step back to the specific learning health system characteristics that I think are most specifically dealt with in this report. I highlighted the 5 here, and as I said, you could probably make an argument that all, if not most of them, are dealt with in one way or another. But just to simplify things, I think it's pretty straightforward that digital technology is really, this engine for continuous improvement is really at the heart of what we're talking about here. But also, of course, the health information, which we state as needing to be a reliable, secure, and reusable resource, as well as a data utility, which is this data made up of health information, which needs to be stewarded and used for the common good. So these are the sorts of things that we're talking about here. Taking it a step beyond that is, of course, knowledge, the knowledge that is created by the system, as mentioned before, in an ongoing manner and is a seamless product of services and research. And, of course, ultimately, what we're talking about is building a system that will support the ongoing constant assessment and improvement of health outcomes and dealing with cost. So next slide, please. So the workshop series was planned and orchestrated by an amazing group of folks who made up our planning committee. Laura Adams, who, well, I'm sure most of you are familiar with most of the names on this slide, but Laura Adams, who is the president and CEO of the Rhode Island Quality Institute, served as our chair. And really, it was through these folks' hard work, dedication, and really donation of a lot of time and input and guidance that we were able to really pull this together in as quickly and as well as I think we did. So I just wanted to take a second to acknowledge the planning committee and to thank them for their efforts. Next slide, please. So the first thing that the planning committee did was to ascribe an aim for this workshop series. And the way that they defined it was to identify and explore strategic opportunities for accelerating the evolution of a digital infrastructure that will support and drive continuous improvement in health and healthcare. And really, what we're talking about here, to tie it back to Chuck's equation, is to start defining that delta and to start thinking about how we might start to get there. So this other there that is necessary in order to build on the foundation that exists through meaningful use and through other ongoing initiatives to get us to that learning health system. So the way that they went about this had to do with fostering a shared understanding of the vision, exploring the current state of the system, and then starting to, of course, identify priorities and starting to ascribe strategies and actors to those. The workshops themselves, as Chuck mentioned, were held in the summer and fall of last year. They began with a July workshop where we invited a large number of experts in a wide range of fields of relevance to this, to really outline what they saw as the opportunities, challenges, and priorities that were going to be necessary to take into consideration in this journey. The following September workshop really started to look at what that next system was going to be. So where did we want to go? What sorts of functions did we see this learning health system as needing to support? And what were those foundational efforts that existed that we wanted to make sure to leverage and to really use to our advantage and not start to think about trying to rebuild something that already existed. Finally, the October workshop was really now about connecting those two dots. So having stated where we are and having a better sense of where we want to go, start thinking about how we need to get there. And so that consisted in considering some strategy elements and opportunities and talking about responsibilities and next steps, which I'll talk about a little bit more. Chuck mentioned, and I think the discussion across these workshops really started to coalesce around 4 areas that I think might use slightly different words, but I think you'll find very similar, familiar to the points that Chuck made when he described what how a learning health system is currently envisioned. So they really started to focus around, of course, sort of technical progress. And so Chuck talked about sort of a focus on a federated system and a need to standardize just enough but not too much. They also focused the discussions around knowledge generation and use, which is the words that we use to describe what are we going to be doing with this system? What will this federated system be used to do? Patient and population engagement, as Chuck mentioned before, was really at the cornerstone of what people kept going back to as being really necessary in order to really make this happen. Talked a lot about the need for participation across, the patient communities, the clinician communities, and that has to do with privacy and security, but also a demonstration of really what we're doing and how this is a good. And I'll talk a little bit more about that in a second. And then finally, another area of focus was around governance, and Chuck mentioned this as well. And he described it as participatory governance, which is, of course, one of the major themes, and I'll talk a little bit more about some of the other sort of specific nuances that the participants talked about. So next slide. So the report itself breaks down into 5 general sections. Our first section is a synopsis. We call it synopsis and highlights because although we would like to call it a summary, it's a comprehensive summary, and it may be too long to be called that. But we wanted to make a section that was more accessible than the longer version. The common themes and principles I will be talking about in more detail, but that really starts to pull out those major common themes that arose in the discussion across those 4 areas. The next section, the opportunities, challenges, and priorities, I won't get into the details of, but suffice to say that the expert presentations that we brought in during, in particular, the first workshop, are captured there in their entirety. So there's a lot of really excellent manuscripts that detail everything from the vision of what a learning health system should look like and the digital infrastructure that underlies it on the part of clinicians and patients to some more technical focused discussions about what the security system around such an infrastructure should take into consideration, as well as a discussion of the global dimension, which is necessary to consider when you start thinking in learning health system concepts, because of course these questions and answers and considerations don't stop at national borders. Finally, the report sort of concludes with a greater distillation of some of those concepts, and then finally our accelerating progress section, which I'll also talk a little bit more about, really points to some specific things that can be done or can start to be done now, and who we think should really be taking those sorts of issues on. So at this point, I'll just sort of go ahead and dive in and talk about those 4 areas that I mentioned before and that were sort of the foundation that Chuck used to describe the learning health system. And as I mentioned before, the distinction between some of these is a little bit artificial, so just bear with me on that note. So, for example, starting with the technical progress section, one of the common themes was that discussants really felt that it was going to be necessary to anchor such an approach in an ultra-large-scale systems approach. And actually, if you can forward the slide one more, I have just a really quick primer on what an ultra-large-scale system is, because this is something that we know is not necessarily, sort of commonly used in many circles. But this is a concept that was brought to the discussion by the sort of computer science community. And I guess I should mention here that I think one of the great characteristics of this workshop series was the ability to bring together folks from really across a number of different disciplines who I think had been thinking about a lot of these issues sort of within their own worlds, but seemed like for the first time were really starting to talk the same language, or at least come together on sort of common concepts. And one of the ways that happened was around this ultra-large-scale system. This is a set of characteristics that can be used to describe a system, and it has to do with with the characteristics that are due to the massive scale of such a system. So they have to do with decentralization, including inherently conflicting and unknowing requirements, continuous evolution and deployment. So as you start to think about this, you can see how, although these were terms that hadn't been applied to health and healthcare previously, how relevant they are and how accurately they really do describe such a system. So if I can get you to move back one slide, please. Back to, technical progress, great. Because of this sort of acknowledgement that this is a set of characteristics that really describe the health and healthcare system well, this suggests an approach, and that approach is really one that is based on a set of technical and social principles that meet the current and future needs of a complex system. So it's a system that, as Chuck mentioned, is really minimally standardized and is really meant to foster innovation and personalization and emergent behaviors. The next common theme that arose in the discussion of the technical progress was about emphasizing decentralization and specifications parsimony. So this was really hand-in-hand with the ULS systems approach. So it's the importance of not over-prescribing approaches and really encouraging innovation that will allow local needs to be met. This is, of course, also in line with the complex adaptive qualities that have been prescribed to healthcare before, in particular in some of the previous IOM reports, such as the Quality Chasm report. Really, one of the foundations of that report is relating health and some of the complexities around healthcare to those principles, which are really in line with the ULS approach. So given these common themes, how did folks think that we needed to move forward? Well, I'll highlight three of them in particular, the first of which is technical acceleration. So really creating a collaborative vehicle for computer scientists and the health IT community to come together. As I mentioned, I think that was one of the breakthroughs of this group of workshops, and I think there was an acknowledgement that this was a conversation that needed to be continued and could really serve to drive innovation, and these discussions could happen across sort of academic, public, and private stakeholders as we're all present in the meetings as well. Secondly, they called for a ULS ultra large systems test bed. So one of the concepts that came up time and time again was the need for sort of rapid prototyping and failing early. And so really the need to identify opportunities to test some of these suggestions and characteristics and learn more about the implications of taking such an approach. There's a little bit more specificity in the report that deals with sort of taking a more canonical engineering approach to thinking about some of these issues, which folks seem to think would allow for a new perspective on some of these issues. And then finally, in terms of the technical progress, the target that was called out was interoperability, which is, of course, continues to be a struggle, but also an area where there is a lot of progress. We had at the release on Monday, Dawn Milliner, who is the CIO of the Mayo Clinic, and she, sort of relating back to some of the themes of the report, talked about the experiences at Mayo and talked about how interoperability continues to be a struggle. And so obviously there's a lot of work that needs to be done, and of course a lot of very capable and smart folks are dedicating a lot of effort to this, not the least of which is, of course, the ONC S&I framework. But, of course, there is still a long way to go. And it is obviously really crucial to the ability for something like this sort of a system to work. So, great. Thank you. knowledge generation and use is the sort of the second of the four major categories that the discussion's focused on. And here, really what the major theme that came out was about embedding services and research in a continuous learning loop. And it's really about embedding the functions that we want the learning health system to be able to carry out in a way that is seamless and does not impose further burdens on the folks who use it, and really provides a useful format for both the clinicians and the patients to interact with. So what are the things that need tending to in order to work towards this? The discussions really brought out a need for what we call functionality standards. So that's really standards for the core functions of the digital infrastructure. So one of which is, of course, supporting care, but more specifically and in some ways unique to sort of the learning health systems approach, there's the need to support research, public health monitoring, sentinel event detection, quality reporting. So really focusing the standards effort on supporting those learning health system functions. Secondly are the quality measures. And quality measures specifically calling out the need for the measures that focus on outcomes and that can again be embedded in a process in a way that makes them easy to do and can also support research and reporting. And then finally, clinical research, which is to say a cooperative network that can advance clinical research in this new environment, which is, as Chuck described before, will almost certainly be a distributed, federated environment and will, of course, need the development of novel methods and approaches in order to be able to do this. Of course, there are a number of ongoing efforts, such as the HMO Research Network and Sentinel, which are already making great progress in this area, but now thinking about how you sort of take that to the next level in terms of scale. And then, of course, some of the associated considerations that go along with doing research in these sorts of environments, such as data integration challenges, the identification strategies, consent in a federated environment, all of those sorts of things. But really focusing on the need to develop those methods for query-based research and signal detection, and, of course, the associated standards that will go along with that. And this, I should have mentioned this earlier, I think this really is focused on what Chuck talked about as that sort of analysis component of the learning health system, that going from data into knowledge that is such a necessary part of the process. So next slide. So patient and population engagement has already come up a few times, and as Chuck mentioned and I did as well, was really brought up over and over again and really pointed to as such a necessary component. You can have all the right technology, but if you don't have folks who are willing to participate, whether it's the patients or the clinicians, you don't have anything. And so the way that this played out in terms of the themes that were discussed had to do with the focus on building a shared learning environment. So really taking advantage of participation from all people, or all stakeholders, basing decisions on input from all parties, and that includes, we really were very explicit in saying that this is not just about the patient, but it's about the population and the health of the population as well. Weaving a strong and secure trust fabric among stakeholders, Chuck already alluded to that too, and this, of course, has to do with security and privacy concerns, but also being honest and forthright in communications with the public and all stakeholders about the risks and benefits of such a system. The participants really felt strongly that the need to have transparent and honest conversations was really the only way to build a strong foundation of trust. Fostering a socio-technical perspective focused on the population. this points back a little bit to this, one of the major components of the ultra-large-scale system characteristics is this acknowledgement that there are social as well as technical components to these systems, and often the social and cultural aspects of these challenges can be more challenging than the technology. So it's really taking those into consideration in every step and in every component of the approach. Targets for action. There was a lot of discussion around the case. So needing to address sort of the business case or the value proposition on the part of industry, on the part of patient participation, on the part of clinician participation, and they really thought that highlighting that as needing attention in a very specific way would be a great sort of step forward in moving along and engendering that engagement that is necessary. And then, of course, involvement. Initiatives that will involve stakeholders across the board in active ways. And of course, this is already going on to some extent, but the need to continue that and to improve as necessary. And then finally, next slide, governance, which is our final theme. This was in some ways I think posed the largest challenge for participants, but I think we really came away with some great insight. So that some of the themes were, as we have already pointed out several times, really the need to leverage existing programs and policies. So meaningful use has been brought up a number of different times, but the participants also considered a number of other efforts that are going on in these little pockets of innovation, and as I mentioned also, HMO Research Network and Sentinel, really folks that are on the leading edge of starting to build some of these systems and use them in a way that is consistent with the learning health system. Leveraging that and really taking advantage of that and not reinventing in a way that can accelerate progress and prevent waste. So then, second is to engage health and healthcare, the patient and the population. This was also a major theme that fell out kind of across the different areas, and that really has to do with thinking in terms of what happens beyond the doctor's office and the health decisions that are taken in everyday life, and how much more they really can affect health. And the opportunity that technology increasingly allows us to capture information that's associated with these sorts of extra healthcare system activities, and really using that to its maximum potential. And the second half of that is thinking beyond individual patients and starting to think about population health and the health of the nation. Third is to keep the barriers to use low and complexity incremental. This also has colorings of the ULS approach, as well as that participatory governance structure that Chuck talked about. So this is really about encouraging maximum participation and letting individuals determine how they want to use the system as a way to increase participation, foster innovation, and really meet those requirements. Finally, in terms of the governance themes, is to provide continuous evaluation and improvement. The learning health system is really all about providing continuous assessment and improvement. And so, of course, building a process of that same flavor into the creation of the system itself was something that was pointed to often. In terms of targets for action within governance, the sort of overall governance and coordination, the need to specify principles and priorities, specifications, and cooperative strategies was mentioned. And as Chuck pointed out, there is an effort that is related to this going on currently as part of the statute requirements. And so folks talked about how thinking about governance of a learning health system might be a little bit different than thinking about the sorts of civic governance that group is talking about, and how the need to support things like clinical research and monitoring would bring up governance questions and issues that the other group may not deal with. And then finally, identity resolution. This is an issue that seems to come up over and over again, and it's a major hurdle that needs to be overcome. And so establishing a consortium to address this sort of identity resolution, which is important not just when it comes to care coordination, but obviously is integral to being able to do the sorts of clinical research that will be necessary for this sort of a system. So that's it, I think. My last slide. Yes, great. And so I guess with that, I will pass the podium back over to Chuck.
Okay, thank you, Claudia. I'm going to be very, very quick in closing because I want to allow at least a little bit of time for questions. I believe that's in order at the end, and I trust I'll be corrected if I'm not correct in that assumption. So here we go with the third part. I'm just going to discuss briefly some of the things we are beginning to do to build out the Delta, recognizing that in parallel there are enormously important efforts ongoing to build toward national meaningful use. Whoops, went too far. So in building the Delta, we have some very specific, interesting activities that are getting underway, and I want to mention a couple of them. One of the activities we are undertaking is within the government. We are actually beginning to build what we're calling the Learning Health System Working Group, and we have included in this group 7 projects of 4 agencies that are themselves mini learning health systems. And we are working together to explore a hypothesis of whether they could join together in principle to form a single learning health system using shared technologies and policies. I want to emphasize that this project is not actually merging these 7 activities, but is exploring whether it would be possible to do so. The result of this exploration could point the way to how many independently operating, call them islands, that are themselves self-contained learning health systems might over time come together very much in the spirit of this ultra-large-scale system approach to grow toward a national system. So we're very excited about this effort and the enthusiasm that it is generating. We are also, again, going to work with the Institute of Medicine, and we're delighted about this, on a new study that will explore a question that is absolutely critical to the development of a learning health system, which goes to the question you see on the slide here, namely, what levels of data quality are really needed for different types of learning? The learning health system, when it's fully developed, is going to have different kinds of data available for analysis, ranging from data that are routinely accumulated as part of healthcare, again, to be reused only with permission, but also at the other extreme, data that were purposefully collected for purposes of carrying out prospective randomized clinical trials. These are very different kinds of data. They have different characteristics. One is very, very broad, but less standardized and coherent. The other is much more narrow, but much more standardized and coherent. So they are going to be useful for different things and different purposes, and this really does need to be explicated. Finally, another plan we are embarking on, or another project we're embarking on for 2011, is to begin thinking about a lightweight approach to what we are calling distributed query, the ability of a question, a population-based question, to be placed to different entities, which could eventually be different members of a learning health system, and how this could, in a very straightforward way, be carried out without the need to build a lot of cumbersome technology to, in effect, do the kind of virtual data aggregation I was talking about. I think this is an example of how we are going to work in collaboration with the rollout of meaningful use and building out the Learning Health Systems Delta at the same time. So I just wanted to share some of the excitement around those projects. So to bring my piece to a close, then, if you don't get a chance to ask your question today, please feel free to write to me. I know that that same offer goes for Claudia as well. And if you want to know much more than we had time to talk about today about efforts ongoing in the National Health IT agenda relating to meaningful use and increasingly to the development of a learning health system, you can, of course, access a great deal of very rich and valuable information at healthit.gov. So thank you very much. And is it appropriate to entertain a few questions at this point?
Yes, Chuck, this is Kate, and I'd like to just say first, Claudia and Chuck, what wonderful presentations. I mean, there's so much interesting and thought-provoking work underway, and we do have some questions flowing, so I'd like to just try to manage a few of these, but I want to start by saying that any of the questions that have come in that we don't have time to address live today, we will ask our speakers to work with us offline and get all those questions answered and posted. But so a couple questions, just to kind of categorize. So Claudia and Chuck, could you maybe just elaborate a little bit on what role the various different stakeholders can play in, helping us make progress toward the learning health system, organizations like pharmaceutical companies, devices, public health, et cetera, as well as, how can the patient be, I mean, you touched on this, but, what's the patient's role? So if you could just talk a little bit about the different stakeholders and how they can help us make progress in this direction.
I'll just start. Claudia, do you want to tackle the patient part of it after I make an introductory remark? Because I know that was very heavily addressed in the report. Is that okay?
Sure.
Okay. So first, in general answer about the stakeholder engagement, that question could take another 90-minute seminar to address, and I think for those who had their palates whetted by this presentation, I would invite you to the next two, where a lot of ways in which specific stakeholder groups can engage will be detailed. I want to say very generally that I hope my diagram, where I tried to draw what a learning health system would look like, made clear that different kinds of organizations can be part of the system, playing different roles. All of that has to be worked out, but it's clearly not a one-size-fits-all proposition, and pharmaceutical companies and healthcare delivery organizations, payers, the whole panoply of stakeholders will have a role in the learning health system that we envision. The roles may differ in detail, but in general, all of them can be participants in both the afferent and efferent operation of the system. And then there's another kind of stakeholder, which are the islands of learning health system excellence, which already exist across the country. There are many learning health systems all over, and part of the challenge we face in building this out to national scale will be to do this in a way that brings all of these mini learning health systems islands of excellence together. Claudia, do you want to address the patient participation part of the question?
Sure. I mean, I think really the patient participation question is sort of an extension of the kind of framework that Chuck has already laid out in terms of stakeholder participation in general. I mean, I think one of the items that came up a lot was really the opportunity to work through some of the patient groups that already exist as a way to sort of start to access this concept from the patient perspective. You know, there are a number of groups. First and foremost that I can think of, you know, United Healthcare has a whole advertising campaign around using data to improve health. So there's clearly an active outreach going on. And I think increasingly as patients become more activated and more engaged directly through the use of PHRs and those sorts of tools or remote monitoring, I think there's going to be increasingly a role for their input. And that sort of, it rides along the same wave of, as I said, increased patient engagement and activation and patient centricity, which, you know, we talk a lot about, but figuring out exactly how to implement it can be a little dicey. So I think there's a lot of opportunities there for patient engagement, and I think it's something that, as I said, we say a lot about, but the implementation of which I think we find sometimes harder to do.
Good. So I think we maybe have time for one or two more. So we have a question that's come in that relates. So is technical progress toward developing the learning health system, how does that relate to, or is it dependent upon some of the recommendations in the PCAST report? Could I guess maybe Chuck? I guess I'll throw that your way, but maybe Claudia has thoughts as well.
Yeah, that's a great question. I think that the PCAST report, if one reads it from cover to cover, is just run through with themes that invoke the learning health system. The vision in the PCAST report of interoperability and universal exchange language is a way of expressing elements of a technical architecture that will make a learning health system work. So in parallel to all this other thinking that has been going on and profoundly complementary to it, here comes the PCAST report with a set of very important, completely complementary ideas that are going to be enormously helpful to propel us forward. It's an extraordinary synthesis that we're seeing taking place.
So one last, I think this is our last one, and again, we'll complete all, we'll get all these questions answered offline. But so how do you guys envision tracking progress toward achieving the learning health system?
Claudia, you or me?
Well, I can I guess say from our perspective, we sort of view ourselves as serving as a focal point for keeping this series of conversations going, not just in the realm of health IT, but everything from sort of dealing with the professions and clinicians to the sort of marketing and communication parts of this. So tracking impact is always a challenge. But I think, for example, as Chuck described, the inclusion of this in such an explicit way in the ONC strategy plan, although it was present in spirit there before, I think is just a great example of how this is really starting to get traction. And I think that's also a function of just this amazing opportunity that we have in time right now.
Yes, Claudia, thank you, because that second point you made is exactly what I was going to say. The presence of a learning health system as one of 5 strategic objectives in the new strategic plan will set in motion a kind of further process that translates the strategic objectives into tactical objectives and tactical objectives into timelines and roadmaps that will inevitably lead to one of possibly many ways in which progress toward a learning health system is tracked.
Wonderful. So we're going to have to bring our session to a close. Chuck and Claudia, thank you so much. This was our introduction to the learning health system. We will have a couple of follow-up sessions that go a little deeper on some topics. But thank you so much, Chuck and Claudia, and thank you everyone for attending and participating. And we will post the additional Q&A as we complete them. But I would just ask those of you on the line to complete the short survey. We really need your feedback. So there's just a couple of questions there that we'd like you to just answer. And again, thank you so much, everyone. Chuck, Claudia, that was wonderful. And a happy Memorial Day weekend to everyone.